Hello, everyone, and good afternoon. Welcome to our final session in our virtual series on advancing young adult health. I am Erin Hemlin. I'm the Health Policy and Advocacy Director at Young Invincibles. For those of you who may be new to us, YI is a national nonprofit organization dedicated to advancing economic opportunity for young people and amplifying the voices of young adults. Our first two panels in the series tackled coverage disparities among young adults and the growing mental health crisis young people are facing, both of which have been exacerbated during the COVID pandemic. And today, we're ending our series with a discussion about medical debt, and more largely, the high cost of care, lack of affordability, lack of cost transparency when accessing healthcare services. I'm looking forward to a great discussion with our excellent panel today, but before we get started, just a few quick reminders. Today's conversation will be in listen-only mode, but please do use the Q&A button to submit your questions and comments throughout the discussion. We will save some time at the end to address all of those audience questions. You can also use #YoungAdultHealth to follow and join the conversation online. As I introduce our panel, we want to know who you are as well. So we'll have a few poll questions throughout today's call, and this will be the first one. So please take a few moments to answer the poll that should be on your screen now. Great. And while you take a few moments to do that, it is my pleasure to introduce our panelists. I'm so happy to have the speakers that we have today, not only because of the incredible work that you all do, but because this is a conversation about the health of young adults, and our panel is made up of all young adults today, which is pretty great. We are joined today by Diana Zhang, Outreach and Engagement Manager for the Women's Health Program at Community Catalyst, Deborah Steinberg, the Healthcare Attorney at Legal Action Center, Jessica Siegel, Senior Legislative Assistant in the Office of Congresswoman Katie Porter of California. And finally, we are very excited to be joined by one of our own young leaders, Tanisha Saunders, an alum of our Young Advocate program out of our California office. Now, before I turn it over to our wonderful panel, I want to start with just some opening remarks about how medical debt impacts young adults specifically, and to share some of what we hear from young people at YI. Despite kind of conventional wisdom that older adults are more likely to incur medical debt due to higher medical spending, a recent health affairs study actually found the inverse to be true. Even though young adults do have lower medical spending, they tend to have higher medical debt. The study found that the share of people with at least one medical bill in collections peaks at age 27 and holds steady until about age 40 and then begins declining. The study, like many others before it, also found a correlation between insurance rates and medical debt. Again, the less likely you are to have insurance, the more likely you are to have medical debt. And as we know, young people are less likely to have health insurance. About 15% of young people between 18 and 34 lack health insurance, compared to just 9% of the general population. Furthermore, millions of young people are underinsured, where they may be enrolled in employer or ACA market coverage, but with such high cost sharing that it really provides little protection. The trend toward high deductible health plans has left many young people unable to truly access care when they have deductibles as high as $3,000 or even $5,000. And while ACA coverage and large employer coverage will protect you from truly crippling medical debt, some of the protections from the ACA, banning annual and lifetime limits, creating out-of-pocket maximums, have helped cut bankruptcy rates in half since the ACA was passed. However, the most common bills to end up in collections among young people aren't several $100,000, but on average, less than $600. At Young Invincibles, we held a couple focus groups a few months ago to learn about what young people were experiencing and what they cared about in accessing healthcare services. I want to share a quick story about one of our participants from New York who received an unexpected medical bill. She's a college student, she has health insurance, but lives on a very tight budget, about $20 per week to cover her food costs. She got what she thought was a bad sinus infection and went to see a doctor. And while she thought the visit was fully covered, she ended up getting a bill for about $100 in the mail a few weeks later. And while a $100 bill might be annoying or inconvenient to most can kind of pay that and then move on. But for her, it was a real source of anxiety that she couldn't pay it. She kept receiving notices each month, and it kept putting it off, and eventually that bill ended up in collections. So I think this just shows that it's not just a question of having health insurance, but insurance that needs to include cost-sharing measures that are actually reasonable and workable without several $1,000 deductibles or loopholes for needed care. And of course, it's not just high cost sharing in comprehensive plans, but the explosive growth of non-ACA compliant plans that are a leading driver of debt. In 2018, the Trump administration deregulated short-term limited duration insurance, or short-term plans, so that they could be sold up to 364 days, expansion up from a 3-month term. Short-term plans don't have to comply with ACA regulations, like including the 10 essential health benefit categories. They don't have to include those financial protections against annual and lifetime limits. And most crucially, these plans are allowed to discriminate based on pre-existing conditions and medical history. Just last week, the House Energy and Commerce Committee put out an investigative report that shows the sales of these plans have increased nearly 30% after the Trump administration's new rule was implemented, up to about 3 million enrollees in early 2019. And while we know these plans are allowed to discriminate and deny care, this report confirmed that that's exactly what they are doing. They found that all companies under the committee's investigation require women to disclose whether they are pregnant. Most require women to disclose whether they're expecting to become pregnant in the process of adoption or in the process of undergoing infertility treatment. Women who respond yes are denied coverage. All 8 companies require enrollees and their healthcare providers to provide medical and prescription drug records dating back at least 6 months and up to 5 years, with one company requiring 7 years of records. If they determine that a claim is due to any prevalence of a pre-existing condition, that claim is denied. Consumers who are enrolled in these plans are suffering. In one case, a man enrolled in a short-term plan was billed $280,000 and had his coverage rescinded after seeking treatment for an infection. The reason? His insurer stated that the patient previously had an ultrasound that revealed something suspicious. And these short-term plans are heavily marketed to young adults. That's their ideal demographic. These marketing tactics are often extremely deceptive, appearing to be full comprehensive coverage while hiding their exclusions deep in the fine print. And this is just one of the reasons that makes navigating the complexity of health insurance difficult for young people. And I think a really good reminder that while we want to empower young people to have the knowledge and the tools to make informed health decisions, it can't all be on them. The idea of comparison shopping in health insurance just doesn't work without addressing how these non-compliant plans are regulated and sold. And while the type of insurance you have plays a key role in accumulating medical debt, the benefits and services young people use are key indicators of debt too. For example, the #1 reason young adults between 18 and 34 utilize their health coverage is for mental health care services. However, mental health care is often more expensive and harder to find compared to physical health services. And we'll hear more about why that is from our panelists. Surprise billing practices, particularly from air and ground ambulances, is one of the most well-known drivers of unexpected bills that lead to debt. And we'll also hear more about efforts to end surprise billing at both the state and federal level from our panelists. And finally, there's one more important reason why we're having this conversation today, which is, of course, the coronavirus sweeping the country. The US has now reached 2.7 million confirmed cases with nearly 130,000 lives lost. In order to help stop the spread, it is imperative that people who experience symptoms get tested and get treated. However, we know one of the main reasons people often avoid needed care is due to fear of high costs. The CARES Act was a good first step in mandating that free COVID testing is available to all, and the HEROES Act, passed by the House but still waiting in the Senate, included COVID treatment without cost sharing, as well as protections against medical debt collections. Another great measure, but we need the Senate to act. Now I will stop talking because I'm really excited to hear from our great panel today. Again, I want to thank you all for being here. I know it is late on a Thursday afternoon before a holiday, so really appreciate your thoughtful participation today. So as we get kicked off, we have another poll, we have the poll results, excuse me, to see who's on our call today. It looks like we've got a lot of folks in the policy realm. So excited to hear your questions as we get into this discussion. All right, and to kick off our panel, I am very excited to welcome Tanisha Saunders, again, an alum of our YI Young Advocate program in California. Tanisha is an incredible survivor who's now working as a young leader mentoring youth experiencing homelessness. Tanisha, thank you so much for being here.
Thank you for having me, everyone. Thank you for that great introduction, Erin. I've had the pleasure of working with Young Invincibles since 2017, where I've had the opportunity to share my story, to network, to attend conferences along YI, and to be a young advocate, learning about the legislative process, learning how policy is created, and pushing to advocate within my community, my peers, and my family. So I'm honored to be here today. I saw the poll results. I'm curious about who the other population is, because that's quite a lot of people as well. So it's great to see that there's a mix of folks in the room and taking in this information. So again, I'm happy to be here and learn from you all, because I think learning is something that is continual as things are moving, as we're experiencing COVID and learning the new normal, quote unquote. But as a person with lived experience, who's experienced homelessness, who's navigated our healthcare system, or had the healthcare system like navigate me, I'm excited to share my insight, share my story today. So because of the work that I've been doing, I've had the opportunity to share information with my community and my peers and my family, and have conversations about healthcare that we weren't necessarily having. And it's not because, you know, education or work, these conversations just weren't penetrating our community. And even on my school campus, I noticed that we weren't having these important conversations about healthcare. And unfortunately, I had negative experiences with the healthcare system. So I spent my time focusing on systems change that will positively impact so-called non-traditional students, because that is my background. I went to school at a later age and didn't have access to a lot of supportive systems. Because I am a former foster youth, I did experience homelessness. So I became someone who empowered others, not just by my story, but empowering others to show up and vote and be educated voters. And as we say in YI West, civic engagement is an action word. So just not saying words, but when we log off, putting those things into action and learning who our local leaders are and participating civically. So about 3 years ago, actually 3 years ago next month, I unfortunately was a victim of gun violence. And I had a physical impairment. I lost my eyesight in one of my eyes, and I was hospitalized for 4 days. So it was a really hard time for me, because here I am adjusting to this traumatic event that happened and learning how to move forward. While I was in the hospital, I was very confused. I didn't know a lot of the terminology. I didn't really have a lot of active engagement with nurses and my doctors, and I didn't have a lot of clarity around just what medically was happening to me. So once I got out of the hospital, I was able to enroll in school, and I started my school semester about a week later. So as you can imagine, that's just a lot going on, experiencing gun violence, being in the hospital, and then transitioning into finishing my final year of college, all right in front of me. So about a week or two after I got out of the hospital, I started to receive my medical bills. First things first, I didn't realize how expensive it was to get an ambulance ride. I think I would have tried to call an Uber. Out of an unfortunate situation, here I am, you know, receiving life-saving services, and then within 2 weeks, I get hit with bills. And so I was just overwhelmed. I didn't have someone to explain the bills to me. Fortunately, because I was a victim of crime, I was enrolled in a program that advocated for me and helped me with those bills. But I just started to think, here's $13,000 worth of bills that just came on top of experiencing trauma, and I didn't know how to navigate that alone. To say the least, it was difficult navigating rehabilitation, education, let alone mental health. I did have health insurance. It was public health insurance, and I didn't necessarily appreciate the quality that I received. So I had a negative experience in the hospital that really pushed me away from seeking further assistance with mental health. I located mental health services on my campus, which was included with our tuition. So I assumed a lot of my original insurance would have covered the cost of those emergency services, but obviously when the bills came and then when the collection, it moved really rapidly too. It was like the bills came, okay, no response. A month later, then it was sent to collections. And so I was just overwhelmed. So I adopted the catch me if you can philosophy. But again, thankfully, there was a program to assist people who were victims of crime. But other than that, I would have just been like, I have to focus on school and be done with school. So thankfully, I was able to graduate school and continue my partnership or continue my work with Young Invincibles to find out that my story, unfortunately, isn't rare. It happens to a lot of young adults, and navigating the healthcare system is really confusing. And like you mentioned, someone received $100 bill. A $20 bill would have been a lot for me because I was in school and I wasn't working, and here I am having a physical impairment. So all those things where you don't have an opportunity to speak directly to someone to share your story made it even more difficult. So because of my work with Young Invincibles around healthcare and health insurance advocacy, I learned so much about health insurance and how to navigate the healthcare system. And unfortunately, many young people don't have those opportunities. So I became an advocate in my community. And I think it's very unfortunate that people are dependent on having jobs that provide them with health care. I don't think that that's fair, especially with young adults. As myself, prior to experiencing gun violence, I had to choose between work and going to school full time, and that's hard to navigate. Or the job opportunities that I could take were part time, and again, didn't allow for me to get health insurance or quality benefits. So a lot of my friends and family they were doing crowdfunding, GoFundMe, and things like that. We see that all the time for people who encounter medical bills. And I don't think that that's fair. And I don't think that that's just for people to be experiencing trauma. And then on top of that, they have to worry about how to pay for their life-saving medical bills. Young Invincibles made learning about policy fun and approachable, and I've had a great time reaching into my community to empower young adults and young leaders while navigating the harsh realities that we're experiencing today. So I'm honored to be here and continue on the panel. Back to you, Erin.
Thank you so much. I am so glad that you're here today, and I really, really appreciate you sharing a personal story, but also just such an incredible story of you as a survivor, as just an incredible leader. And I thank you so much for being here. Okay, next, it is my pleasure to turn it over to Deborah Steinberg, who is a healthcare attorney at Legal Action Center. At Legal Action Center, Deb works on federal and state policies to expand access to equitable substance use disorder services through their insurance coverage, and through the Parity at 10 campaign, works to help states enforce the Mental Health Parity and Addiction Equity Act. Prior to Legal Action Center, Deb was a Equal Justice Works Fellow at Health Law Advocates, where she worked directly with many low-income people and young people in Massachusetts to combat barriers to mental health and substance use disorder care. Welcome, Deb.
Thank you so much, Erin, and thank you, Young Invincibles, for having me. As Erin said, my name is Deborah Steinberg. I'm a health policy attorney at the Legal Action Center. And before coming to Legal Action Center, I had an Equal Justice Works Fellowship where I represented low-income individuals in Massachusetts with mental illness who were denied health insurance coverage of mental health care services or who were experiencing medical debt. And the main factors that contributed to medical debt for these individuals were being uninsured or being underinsured, having inadequate networks in their insurance coverage, especially for culturally competent, trauma-based, or specialized mental health services for people with co-occurring conditions, as well as significant barriers to care within their insurance plans. For example, unnecessary requirements that they get prior approval from their insurance company for a mental health service, and that then would delay treatment and lead to more costly urgent care as a result. And these types of issues I'm describing, they affect all young people, but they were more prevalent and more problematic for people with mental health conditions. So the policy work I did in Massachusetts focused on these types of issues. And now I'm at the Legal Action Center, where we're doing similar work in more states and on the federal level to combat these types of practices. So one key policy issue for stronger enforcement of the Mental Parity and Addiction Equity Act 2008. And this law says that insurance companies can impose barriers that are more restrictive to health and substance use disorder care than for other types of care that would fall into like the medical surgical category, like diabetes or asthma. But recent court decisions and state reporting and examinations reveal that many insurers are still violating this law, and not enough is being done to enforce it. So part of that policy work also includes ensuring network adequacy, which is part of Parity, which must also include really competent and specialized providers. And then making sure that patients are not financially responsible when they do need to go out of network. So often patients go out of network because their insurance is inadequate, doesn't meet their needs, and those patients incur additional medical debt out of network when they really only had this false choice about staying in network. So the legal actor is advocating for these types of policies, strengthening the parity laws and their enforcement, holding insurers accountable when they fail to meet network adequacy requirements, protecting patients who need to go out of network when they can't access in-network services, and ensuring that all people, especially Black, Indigenous, people of color, and people involved in the legal system, have access to affordable, culturally competent, and comprehensive care. So thank you. Back to you, Erin.
Great. Thank you so much for that incredible work you're doing. And next, please welcome Diana Zhang, who is the Outreach and Engagement Manager for the Women's Health Program at Community Catalyst. Based in New York, Diana engages women and LGBTQ people to become informed healthcare consumers. Diana, we are so excited to have you here today.
Thank you so much for the introduction, Erin. Hi, everyone. Like Erin said, my name is Diana Zhang, and I'm going to tell you first a little bit about Community Catalyst. We're a national consumer health advocacy organization that works with partners in 40 states, and we work on issues affecting healthcare consumers, such as medical debt, and we are currently advocating to prevent patients from being saddled with unexpected medical debt relating from the COVID crisis. And here in New York, which is where our women's health program, which I am a part of, is based, we are also a member of Healthcare for All New York, which is a statewide health advocacy coalition. And in this capacity, we have been working to interview healthcare consumers all over the state and identify some of the major factors behind medical debt and surprise medical bills in New York State. And we are out of this work came the Patient Medical Debt Protection Act, which is a bill that has been introduced in both chambers of the New York State Legislature that would address some of these major drivers of medical debt in New York. So I'll start off by telling everyone a quick story about someone I met named Felicia. Felicia is a young woman living in Queens, New York, who is a student studying for her master's degree in biology while also balancing a part-time job on the side. And we met Felicia in 2019. And earlier that year, she had started experiencing a very persistent, sharp pain in her mouth. In order to figure out what was going on, she decided to make an appointment to see a doctor at an urgent care center that she has been to before. And she was happy with her service there. And she knew that this was a urgent care center that accepted her health plan that she had bought off the New York State Marketplace Exchange. And the cause of the pain ended up being diagnosed as a fractured root canal, which just sounds awfully painful. But when she thought the ordeal was over, a month after the appointment, Felicia was shocked to receive a $1,000 medical bill from the urgent care center, and her insurance refused to cover any of it, claiming that she went out of her network to receive this care. So this was very confusing to Felicia, as she thought that, I've been to this place before, they take my coverage, what's going on? And turns out when she talked a little bit more to the urgent care center to figure out what's going on, the urgent care center, even though the center itself and the provider she had previously seen did accept her insurance, she did not know that the provider she saw that day about the pain in her mouth was not in her insurance network, was in a different insurance network, and therefore she was now stuck with $1,000 bill. She didn't know that it was possible to go to an urgent care center and have different providers in different networks. And as a result, she was now stuck with a bill that she could not afford as a student. So Felicia's story is typical of a surprise bill that should have been prevented by the New York State surprise billing law that was passed in 2015. New York was one of the first states to pass any protections against surprise bills, and this law is often looked upon by other states as an example for those who are interested in doing something similar in their state. But as Felicia's example shows, even in states with these kind of protections, consumers can still get stuck with large unexpected medical bills. These laws, unfortunately, are not comprehensive. Felicia's story illustrates a problem that we found when we interviewed a lot of consumers, which is that many consumers and some providers even are not aware of this law or don't understand its details. And as a result, a lot of young patients like Felicia don't know that there are steps that they can take to advocate for themselves when they are stuck in a situation that should be covered by this law. And in addition to this issue, our interviews with consumers also identified several other loopholes in the existing law that we hope that the Patient Medical Debt Protection Act, if passed, would be able to address. So first, the bill would make sure that patients are held harmless if they go to an out-of-network provider because of misinformation on the part of their provider or their health plan. As people on this call probably know, most young people look for a provider who is in their network by using online resources, especially the provider directory that is provided online by most health plans. But our interviews indicate that these directories are often out of date, and as a result, a lot of consumers end up with surprise bills when they unknowingly go to a provider who recently left their insurance network. So we want to address this issue so that patients are not held responsible for mistakes that essentially is no fault of their own. We have also found that some healthcare consumers have been able to circumvent the surprise billing law in New York by asking patients to sign financial liability forms that essentially had fine print or clauses that resulted in patients accidentally signing away some of the protections that they should be entitled to under this law. And our bill would close this loophole by mandating that hospitals use a standardized financial liability form so that patients aren't subjected to any of this unexpected fine print that we have found that some patients have encountered. The bill also includes other provisions to generally make the medical billing process more patient-friendly, less complicated, and more transparent. For example, the bill would require that hospitals provide patients with a single itemized bill within 7 days of their visit. As I'm sure people know, after a hospital stay, many patients receive this seemingly endless number of bills for months, sometimes as much as a year after their hospital stay. And this is especially a problem for young people who don't have as much in savings. And as a result, it can be impossible to budget month to month if you don't know how many bills you can expect, or even what month to expect them, or even when they will end. The bill would also require hospitals to report cost data so that New York State can create an all-payer database. That way consumers can compare prices before they choose a hospital to go to for any medical procedures that they need done. So that is a summary of the work that we have been doing in New York State to prevent young people and other consumers from being victims of outrageous medical debt. And if you'd like to learn more about this project, as well as this Patient Protection Medical Bill Act, you can learn more at wethepatientsny.org.
Great. Thank you so much. I'm really excited to dive into a lot of what you discussed because I think you hit a lot of points that I think really impact young people. And finally, we are very honored to be joined by Jessica Siegel, Senior Legislative Assistant in the Office of Congresswoman Katie Porter of California. Congresswoman Porter has been a leader in taking on the high costs of healthcare, introducing legislation that addresses prescription drug costs, and taking on mental health parity. Prior to joining Rep. Porter's office, Jessica represented the needs of rural health communities with the Rural Health Association. Welcome, Jessica. Again, very excited to have you here.
Thank you. Thank you, Erin, and thank you to the Young Invincibles team for holding this discussion today. I think this discussion is even more important in the context of the pandemic that we find ourselves in. In the coming months, we expect that hundreds, if not thousands of Americans will probably face unmanageable medical debt because of the coronavirus pandemic. This began long before the pandemic, but as we've discussed, it will likely get worse, and it will also be far worse for young people. And we know, as Erin mentioned, that being insured is not enough to safeguard against medical debt. In the 2016 National Health Interview Survey conducted by the CDC, nearly 3/4 of Americans said that they were uninsured, that they were insured, but could not pay their medical bills. This is where things like high deductibles, surprise bills, co-pays, and co-insurance all come into play. Co-pays for an emergency room visit alone can be $400 or $500 on many plans. And for a recent college graduate, or even for someone who's been out of college 3, 4, 5 years, who's been working a low-wage job and has little savings, that can be a devastating bill. And as I mentioned, we know this is only going to get worse because of COVID-19. The administration has so far failed to safeguard against disastrous medical costs for those diagnosed with COVID. While testing is now supposed to be free, we know that this is really not the reality for many Americans. We've seen stories of individuals getting bills for hundreds and sometimes thousands of dollars just for a test. After fighting with Director Redfield in a House Oversight Committee hearing just about 4 months ago, and after passing legislation to make testing free, my boss, Congresswoman Katie Porter, ironically got a bill for a COVID test. We asked the administration to issue guidance for insurers who apparently don't seem to think that certain plans are covered under the legislation that Congress has passed, and we have not received that guidance yet. And all of this is just to talk about testing. Treatment can run into the tens of thousands of dollars with or without insurance. And carrying medical debt can have an enormous impact on a young person's financial future. Most young people have just started to build credit, an often confusing tool that should be a good indicator of someone's ability to pay their bills. But the Consumer Financial Protection Bureau has found that half of all overdue debt on credit reports comes from medical bills, and 2/3 of all bankruptcies are tied to medical issues. But at the same time, the CFPB's own research has found that medical debt is not a valid predictor of creditworthiness. Medical debt is often scored the same as all other kinds of debt, even though it is typically, as we know and as the other panelists have discussed, an unpredicted expense. It's not the same thing as an unpaid utility or a phone bill. Medical debt is different from consumer debt partly because it's never voluntary, and in many cases, it's a choice of life or death. Further, scoring models may not be crediting consumers who repay medical debt that has gone into collections. Given the role that credit scores can play in consumers and especially young people's lives, it's possible that they predict the creditworthiness of a consumer as precisely as possible. But medical debt fails that important benchmark. All of this could change with the passage of the Medical Debt Relief Act. This bipartisan legislation that Congresswoman Porter introduced institutes a 365-day waiting period before medical debt will be reported on a consumer's credit report and permanently removes paid off and settled medical debt from credit reports. This creates an important safeguard, and it allows someone to fight a surprise bill or find some way to pay off medical debt before it hurts their financial future. One of the other major factors that impedes access to care, as we've already discussed, and increases medical debt for a lot of young people is the lack of mental health parity. In 2008, Congress passed the Mental Health Parity and Addiction Equity Act to mandate that coverage for mental health care was no more restrictive than insurance coverage for any other kind of care. But over a decade after mental health parity became law, health insurance plans still fail to adequately provide comparable mental health coverage. And as a result, patients lack the mental health services they need, even if they have insurance. This is why so many mental health providers have simply stopped taking insurance, because the battles they're fighting with insurance companies or the low reimbursements they are receiving for care simply aren't worth it to them. But that hurts those who are trying to get care. Trying to find a mental health provider who is accepting new patients and who is taking your insurance is nearly impossible. And if you choose to go out of network, then you're confronted with the complicated process of filing claims nearly monthly. A friend of mine recently told me that she looks at the money that her insurance company owes her for claims that she has yet to file as a savings account. But in reality, it may be months until this claim is approved, if it is approved at all. So Representative Porter introduced the Bipartisan Mental Health Parity Compliance Act. This bill would enable the Secretaries of Health and Human Services and Labor to analyze consumer complaints, to take action, and would require that insurers take a larger role in ensuring that their plans are compliant with the current parity law. This bill requires the secretaries to communicate specific actions that insurance companies must take to remain in compliance, as well as what they are required to do if they are found to be out of compliance. Identical legislation has been passed in both red and blue states across the country, and over a dozen states are expected to pass this legislation either this year or next. But because of the way that health plans are regulated, millions of plans will be left out until something is passed at the federal level. And we've been fighting to get both of these bills included in future COVID aid packages. It's not that these bills are COVID specific, but they are things that make care more affordable and accessible for young people today. And we are already seeing the impact of rising rates of unemployment and of isolation because of COVID on people's mental health. And that is all the more important during this crisis. Congress hasn't really taken any steps strongly to protect people from medical debt. While the HEROES Act does include legislation that is similar to the Medical Debt Relief Act, it only goes through the end of this year. And we know that COVID-19 is going to continue far past December. We've made testing and treatment free, but we know that's not really playing out in reality. And more needs to be done. And we have an opportunity right now to make some fundamental changes happen, crafting good policy that will last long after this pandemic is over, and that will make fundamental changes to reduce medical debt for young people in the future.
Great, thank you so much, Jessica. And thank you again to all of our panelists for being here and sharing all of the important work that you're doing. Now let's jump into some Q&A. As we begin, again, I would love to hear from the audience. So the next poll question should be popping up on your screen in a minute. Please take some time and fill that out. I know we've already touched on a lot of these issues, but again, if you choose the other category, please type in what you're thinking in the Q&A and hopefully we can get to it. Okay, as folks are taking a few moments to think about that, Tanisha, I would love to start with you. Again, you shared a very personal and powerful story of recovery, and I want to thank you for that. But thinking back to your time in recovery when you were receiving all of these bills, what do you think would have been the most helpful, thinking in hindsight, to help you kind of navigate the bills and all the paperwork coming your way?
I definitely believe that an advocate in the hospital would have been very, very helpful. And then as the bills started to come in, I think having a liaison or someone who reached out, possibly who were paired with a certain number of patients, to again help them advocate and sift through the process. I understand my situation was, dire in that I didn't have any control over giving a lot of responses over what I should and should not get, obviously, to save my life. There was another incident probably 9 months after that where I had an infection in my finger and had to go into the hospital for urgent care. And thankfully, they were able to assist me, but they were concerned that the infection wouldn't go away. So they offered to to take me into the hospital and give me a bed. And so I was worried, well, if this is an infection, please help me figure this out. About an hour after they took me in, they discharged me. And again, I got a bill for $12,000. And I was like, for an hour? This is like the Gucci of hospitals here. So it was just, again, surprise billing, not being aware and not having someone who is speaking with you and letting you know what your options are. Someone could have told me, hey, here's medication. You can go home and monitor this. And if nothing changes, please come back. Instead of it being offered like you get a hospital stay. I don't know why it felt like I was talking to Oprah. I was like, yeah, I'll come into the hospital, sure. And being discharged so soon. It's just lack of understanding how things work. So I think an advocate is very, very important, in transparency of, I hate to sound like you're going to get a menu of things to know the price range, but I think that's what's needed to be a better advocate for yourself and to better plan and understand. So it's like, okay, this may be what I need. So I could talk to someone else about different insurance opportunities. I know some hospitals do charity cases where you can get your stay written off, but you can only do that one time. So how can I better advocate for myself, is through the assistance of someone else who works in the hospital, or an advocate, a social worker, someone, but not having anyone and being left to fend for yourself. When the bills come, it's almost too late to try and get on top of things.
Yeah, absolutely. I mean, I think you really hit the nail on the head where it's like you need both things. You need somebody to help support and guide you through the process, but then the process itself has to be simpler. So I think that was absolutely right, and really like leads into our next question I have for you, Diana, where, I mean, even though a $12,000 bill for a 1-hour visit is pretty insane, but it sounds like it really isn't just the bills themselves, but just the sheer complexity of the system, lack of transparency on what things cost that are leading to some unexpected bills. So I'm wondering if you can talk about some differences that you've seen in how young people navigate accessing healthcare and their understanding of bills compared to older patients who maybe are a little more familiar with the system.
So in our interviews with a lot of patients, a pattern that we saw arise is that young people, which this probably comes as a surprise to no one, are much likely to be seeking routine preventive healthcare services on a regular basis. So young people are much less likely to have a primary care doctor, or as an example, the story I told about Felicia, what she probably needed was a primary dentist who she saw on a regular basis. So because of this, a lot of young people don't go necessarily to seek healthcare until it's serious or an emergency, and they go to either a urgent care center or an emergency room because they don't have a regular physician that they see. And because of that, urgent care and emergency bills do tend to be more expensive. But also because of that, a lot of young people, they are aware that those bills are going to be high. So even in a situation like Felicia, where she got $1,000 bill, it also didn't really occur to her to fight it. She did know that by going to an urgent care center, she was going to be facing a larger bill. So I think this is a situation where, kind of like what Tamisha said, where young people would benefit from someone who can help them navigate the system and let them know, like, here's a situation where you can fight and advocate for yourself.
Yeah, absolutely. So kind of building off of that, Deborah, I'd love to dig in more about mental and behavioral health services as a key driver of debt. As I mentioned at the top of the call last week, our panel focused on young adult mental health and kind of the growing need for access to quality care. I know a lot of folks have kind of mentioned lack of providers and their networks, and we've talked about how COVID and everything that's happened over the past few months are really leading to just growing needs of mental health services among young people. So can you share a little bit more about the issues young people are running into when they seek out mental health care services?
Yeah, of course. And first, I just want to highlight what everyone else has said, that the ability to navigate the system requires like a law degree. Like that is literally what I was doing in my previous position. And that's absurd. That shouldn't be happening. You shouldn't need a lawyer to access basic mental health care. So this is something that is near and dear to my heart, and I'm grateful that people are putting words to that. Many of the folks I represented in Massachusetts were forced to go out of network because they couldn't access the care they needed in network for mental health conditions. This is especially prevalent among young people with co-occurring conditions, like having both a mental health diagnosis and substance use disorder, or having a mental health diagnosis as well as a developmental disability. This is also prevalent among people who have experienced trauma, people with language access needs, Black, Indigenous people of color, people who are LGBTQ+, so on and so forth. Insurance companies typically don't recognize those needs, and they deny coverage of out-of-network services by saying that there are in-networks available when those providers are not actually sufficiently trained to meet those needs of their patients. So in Massachusetts, onto Medicaid, even as, sorry, my connection's unstable. I apologize if I'm going in and out. In Mass, I worked to get many clients onto Medicaid, even as a secondary insurance, because their private insurance didn't cover everything they needed. This was critical for many of my clients who were formerly in the junk plans that Erin mentioned that may not have included any mental health benefits or discriminatorily cost more people who have mental health conditions. So getting enrolled in Medicaid gave my clients more options, but often still not the culturally competent care they needed, and many still needed to go out of network. But most states don't even have that option, let alone Medicaid expansion, unless young folks declare themselves independent. So it's a huge issue everywhere. I represented folks who really needed trauma-based care because of experiences like what Tanisha was saying, but also a range of other experiences that I can't even pretend to comprehend. And they couldn't find any providers that were either a reasonable distance away or who could meet their needs. So some of my clients ended up needing to go out of state for treatment because there was not a provider in Massachusetts who could meet their needs. And Massachusetts, which has really, really good healthcare. But the only way we could even get them out of state coverage was to convince their Medicaid plan that there were actually no in-network, in-state providers. And that, again, takes a lawyer, and you just shouldn't need that. So insurers are getting away with arguing that it's a choice for patients to go out of network when really the insurers are failing to meet the needs of their patients by having these inadequate networks. And then these patients either have to pay the full cost of care or they're balance billed for what the insurance company doesn't cover but would have covered if the patient sought in-network treatment. So another big issue that came out of medical database was emergency reports, which both Erin and Tanisha have touched upon. Again, most folks get surprised by emergency transportation bills, but this is especially problematic for people with mental health conditions. First of all, a lot of people who need an emergency transport because of a mental health condition are not in a state where they can say, oh, I'd prefer to take an Uber. Or they're actually being detained by the police. There's, further power dynamic issues that prevent them from having any say in what's happening with their healthcare at that time. Ambulance companies would argue in some cases that a mental health crisis wasn't actually an emergency afterwards, after they provided the transportation. And then folks would get these astronomical bills because they would argue that their insurance didn't need to cover any of the transportation. Even worse, because of inadequate networks, the closest facility that might be appropriate to treat someone's mental health condition might be over an hour away, and that would further drive up these ambulance costs. So then even when these costs were, if they could be paid in full, these bills, medical bills, would still show up on credit reports and interfere with folks' ability to secure loans, housing, jobs, and so much more. So these types of issues really speak to the laws and regulations in place that still stigmatize people with mental health conditions and fail to comply with the Mental Health Parity Act. So by identifying these inequities and advocating for greater enforcement of mental health parity, network adequacy standards, and combating these balanced billing practices, we can prevent a lot of folks from incurring this unnecessary medical debt for mental health conditions.
Great. Thank you so much, Deborah. I think you brought up so many really, important, compelling points about how it can be different when you're in the middle of a mental health crisis and you need access to an ambulance or what the case may be. And I also want to appreciate that you brought up Medicaid expansion. For folks who joined our previous two panels, I'm going to sound like a broken record because I think this was a theme that I talked about quite a bit. But 14 states still have not expanded Medicaid. Huge shout out to Oklahoma. If we have any folks from Oklahoma and the Oklahoma Policy Project on the call today, who voted by ballot to expand Medicaid on Tuesday night. But again, Medicaid is the largest mental health provider or payer across the country. In expansion really across the southern states, could go very far in meeting a lot of these needs. If you saw our poll results popped up a second ago, and it seems like folks are really agreeing with a lot of the things that we've talked about, particularly among the complexity and just lack of transparency in navigating this system. Next, Jessica, I want to turn it back over to you. Thanks again for all of the work that you and the Congresswoman are doing to protect healthcare access, protect young people from growing debt. But building off of what Deborah shared, can you speak more to what does it look like on a federal level with mental health parity, and where is access falling short?
Thank you, Deborah. I think she made a lot of really great points that I was planning to make, so thank you. But I think one of the things that I would like to talk about is the idea of ERISA plans or self-insured plans, which is something that most of us don't really completely understand. It's a very complicated thing. But the reality is there are a lot of plans that are not regulated at the state level. They have to be regulated here at the federal level, specifically actually by the Department of Labor. And it's because of the way in which they're connected to your employer and the way in which the employer pays for part of the insured care. And so what ends up happening is states are passing laws to hopefully make things better. And they're passing these very good parity laws, like the ones that our bill is modeled after. But in essence, they're only able to catch so many plans. And so many people are left out of that and then end up in a situation, like Deborah was saying, where you don't have in-network providers and you don't have those same protections. And there's no enforcement mechanism. There are no teeth until we have all of our plans covered. So that's, I think, one of the really important things that we're trying to do here in DC. And I think it's interesting, over in the Senate, the bill that Congresswoman Porter introduced has been led by Senator Chris Murphy. And it was included in Senate Help Committee's surprise billing package. And I think that that's really important because I think, a lot of these bills that people get for their mental health care are surprise bills in some way. They're not the same thing that happens when you have a crazy ER visit and you have an out-of-network provider that you didn't realize was out of network, but it's still a surprise bill and it's still a cost that people don't fully understand. And one of the things that Deborah was saying about how so many people have to go out of network, a lot of people don't realize that they may have an in-network deductible and an out-of-network deductible. And one of the things I've talked about with the Congresswoman, she said, you have these out-of-network deductibles that are so big that you can keep going to your mental health provider all year long and never hit your out-of-network deductible. And so you are still going to be on the hook for every single cent of that care because you still haven't hit that deductible. So forcing people out of network forces people to pay for care in all different kinds of ways. And I think the complexity of this system just makes it even more difficult. And I want to hit on 2 points here. The first is kind of this idea of under mental health parity, we're really not supposed to have what's called step therapy or protocols. So it shouldn't be, you have to reach this point in your need for mental health care before you can actually get this level of care paid for. But that's not the way that it actually plays out. When I was working in the rural healthcare space, we heard a story about an individual who his psychiatrist said this man is suicidal and he needs the care that he needs so that he does not commit suicide. And his insurance plan wouldn't cover it because he hadn't tried to commit suicide yet. And it shouldn't take somebody attempting to take their life to actually get coverage for the care that they need. Or there's another, I had spoke with somebody who had an eating disorder and was told she actually needed to lose 10 more pounds before inpatient eating disorder care would be covered by her insurance company. And that's ridiculous. And so these different kind of metrics that we have to meet to get the care covered should not exist. And they are kind of one of those things that just got left out of what parity was 10 years ago when we first created that law. The other is the complexity of the system and the complexity of filing claims. And this is something that I deal with every month when I go to my mental health provider who is now out of network because she stopped taking insurance. And I have to file these claims every month and I wasn't getting responses from my insurance company. And I found out that I cannot e-submit mental health claims. There are other types of claims I can submit online. And not only that, but the address for the claims that I'm submitting is different than the address that's actually on the form. It's changed, but they haven't changed the address on the form. So there are probably, and this is just one plan, But this is something that is a broader issue. There are so many different things that insurers are doing that they are just not taking care of the needs of people with mental health, and they are making it intentionally difficult to file these claims.
Oh, thank you so much for sharing that. I mean, so much of that is just insane and so frustrating. But I think, as somebody said earlier in the panel, these are not rare stories. I mean, I think that this is something that happens commonly across plans and across the country. So it's good that we're talking about it. Diana, I wanted to go to you next. I know we talked a bit about surprise billing practices already. There's been a lot of attention. There's been a lot of momentum on both sides of the aisle to get something done federally, in addition to the state work like you're doing in New York. But I'm curious, how have you seen the fight to end surprise billing practices change since the COVID pandemic hit?
I think that since the COVID pandemic hit, a lot of the focus on fighting surprise bills or medical debt in general has become more COVID focused. The bill that I was previously talking about, the the here in New York, progress on that has unfortunately stalled because New York was hit pretty hard and early by the COVID crisis in this country, and so it was an issue that this was a bill that just basically got sidelined. But even though that happened, we did make progress here in New York on a different front when it comes to surprise bills. Healthcare for All New York, the statewide coalition we're a part of, was able to successfully advocate that COVID testing and treatment be covered by emergency Medicaid in New York, which means that now COVID testing and treatment as well will be accessible and available to undocumented immigrants who don't have coverage. So I think it's kind of like like a one door closed but another one open situation. So it's a similar conversation, but it's just shifted focus more to COVID, and that's probably what's necessary right now.
Yeah, absolutely. Deborah, a similar question to you. I'm curious to know, how has your work changed in response to the COVID pandemic, and what do you see as new challenges arising?
Thank you. So yes, COVID has certainly exacerbated barriers to mental health and substance use disorder care. Most providers are unable to operate at full capacity, and the need for physical distancing and the use of personal protective equipment are driving up costs for mental health care providers that are operating on slim financial margins already. A lot of college and university students were sent home and lost access to the providers that they were seeing. Rely on public transportation to get in, and that's not the safest way to go right now. So there are barriers. However, we've seen this significant shift to the use of telehealth, which has been able to fill some gaps in service needs. And that has become a large part of what I do now. So telehealth has expanded access to care for many folks because they can connect with their mental health providers without needing to miss work, without needing to secure childcare or pay for transportation. Many college students could continue seeing their providers even if they were in another state because the federal government relaxed restrictions around that. And these kinds of needs are not going to go away, especially as more people are facing unemployment and furloughs due to the pandemic, and not all universities are reopening. And the need for physical distancing and the use of personal protective equipment is not going to go away until we have a readily available and affordable vaccine. So I've been focusing on what telehealth practices we want to continue after the public health emergency has ended and how we can advocate for those changes. So some of those examples are telephone calls, which were previously not reimbursed in just about every state or public program, and the ability to access telehealth from a patient's home. Typically, that was also limited to only in clinical settings, but during COVID, we've relaxed a lot of those rules. So once the flexibilities go away from COVID, when the public health emergency is declared over, people are going to instantaneously lose access to these services that have allowed them to continue receiving the care that they need. Using telehealth doesn't work for everyone, and we know that, but we want to maintain the option as a fallback for the most vulnerable populations who do need that option, because for contracting the virus, they're experiencing homelessness, or they lack the resources for a camera phone or Wi-Fi, or they're in a location that doesn't have sufficient broadband. So we're advocating for policies to ensure that all of these folks can continue to access the mental health they need as we phase into reopening, as we unfortunately prepare for more surges of COVID. So without these policies, people are going to continue to need telehealth in these ways either way, but they won't have coverage from their insurance. So medical debt will be an even bigger problem among young adults with mental health needs. And that's why it's critical that these protections are put in place and we can make telehealth as ubiquitous as possible to meet the needs of the most vulnerable patients in our society.
Great. Thank you so much. On our panel last week on mental health, we talked a lot about telehealth. And it seems like where before the COVID pandemic, there were all these barriers to expanding telehealth. And then when the pandemic hit, we just did it overnight. And all of a sudden it was fine. And, providers could be paid at the same rates. And I think especially for young people are very comfortable with technology. It seems like a very easy way to kind of bridge some of those gaps, and expanding mental health services to include like the cost of a flip phone or the cost of whatever you need to make sure that you can have that visit. Seems like there are definitely some promising solutions even after the pandemic is over. Tanisha, I would love to kind of hear from you on the same topic, working with youth experiencing homelessness. How has the COVID pandemic impacted your work, and what do you see as additional challenges in accessing healthcare and paying for healthcare services due to the pandemic?
Right. I think for youth experiencing homelessness, one of the things that I have personally seen is this even greater disparity of accessing healthcare. And this was prior to the COVID-19 crisis. Whereas, traditional healthcare facilities aren't something that they can either access or don't feel necessarily comfortable accessing. One of the things Deborah brought up is just cultural competency. And for youth experiencing homelessness, there's a lot of stigmas around that. So one of the things that we provide at my organization as a homeless service provider is access to mental health resources, access to those medical health resources. So when the Safer at Home mandate took place in Los Angeles County, we had to end those services. So the youth experiencing homelessness were cut off from vital services. And it was great that telehealth really sprouted up and really was available. But then for youth experiencing homelessness, having access to phones, having access to the internet are additional barriers for them. And for youth who we are working with, we're transitioning out of homelessness and into permanent housing or different housing opportunities. Virtual and telehealth actually is something that a lot of them that I'm experiencing don't want to access, because on the flip side, many of them like the physical contact and the social aspect. So COVID-19 has really presented many challenges for us working in the homeless services field. So it's difficult for the youth to access those resources. But now that we're kind of into the flow of the motions, we're combining supporting youth in getting access to physical care facilities, and also in our housing programs, we are working with care facilities to bring medical testing and medical care on site. So we're meeting the youth where they're at, and we are also finding ways that we can partially reopen our access center while adhering to the Department of Health's their requirements. So I think the biggest challenge I see is being able to help youth navigate the healthcare system in ways that they understand and in ways that are culturally competent for them. So things that we think are typical for youth experiencing homelessness or young adults, we need to find ways to reach them and listen to them and empower them to be their own healthcare advocates and work with them and learn from them, because it's not traditional in the homeless sector. We're learning so much. But I think just helping them navigate is really important.
Yeah, absolutely. Absolutely. Thank you for sharing that. Okay, I know I've seen a lot of good questions come in through the chat from the audience. So we have one more poll question up here for you, thinking about long-term solutions. I know we've talked about several of these things today, so I'd love to hear from you all where you think our efforts should be concentrated when we think about stemming medical debts from going to collections to start with. As you take a minute to fill that out, I have one more question for you, Jessica, and then we'll open it up to the audience. But just this week, the House passed legislation that could greatly curb medical debt among young people before it even begins. The Patient Protection and Affordable Care Enhancement Act, which would build off the ACA. It has a million provisions in it. We're supportive of basically every single thing. But two I wanted to highlight is the expanding affordability through premium assistance and the incentivizing states who have not yet expanded Medicaid to do so. These two provisions alone would go so far in helping to improve coverage rates among young people and protect them from high cost bills. Unfortunately, we know this bill will not get much traction in the Senate, just as the HEROES Act has not gotten much traction either. But given past bipartisan support for surprise billing legislation and some good positive measures around COVID legislation addressing COVID-related out-of-pocket costs, where do you see opportunity for bipartisan action this year?
It's a really good question, and it's a really hard one. But I think the thing is, you mentioned the Medicaid expansion and the support for Medicaid expansion that's in this bill. And we saw Oklahoma, as you mentioned earlier, expand Medicaid yesterday. And that's a deep red state. And I think, we look a couple years back at when Republicans were trying to repeal and replace the ACA in the Senate. And I don't think we're going to see Republicans expanding the ACA anytime soon, but it's become much more difficult to rip the ACA away from people, despite what the Trump administration is doing in the courts. It's become a lot more difficult for people to vote on this, to vote on decreasing access to Medicaid, because that has become kind of almost like a third rail for these programs that help support people. And it's really the only one when you look at Social Security, Medicare, and Medicaid that supports young people. And it's become harder and harder for Republicans to decrease access to Medicaid. So I'm hopeful that maybe in some form in not the HEROES Act, but in whatever next COVID aid package we are passing, that we'll see some sort of support for Medicaid and something that's bipartisan. I don't think it will be exactly what was in the bill that we passed this week, but I'm hopeful that there will be something. Maybe I'm being too optimistic, but I do think it will be there. And you mentioned surprise billing. And I think it's really important to know that while we've had bipartisan support, there's been a lot of controversy over really what to do and how to solve this problem. And I think that it's important to figure out how we move forward because we still do need to pass a surprise billing package this Congress. Originally, we had hoped to do it this spring. And I think that it's something that, again, looking at what's happening with COVID-19 has become even more important than it already was. And there is bipartisan agreement and we just need to get to a deal. Mm-hmm. And I hope that will happen soon. I think in the mental health space, we've seen an increase in bipartisan action in the last few years. Coming from the rural health space, I saw the incredible work that was done on the opioid package that was passed 2 years ago now, the Support Act. And we're seeing, there's still a lot of stigma around mental health, but it seems to be breaking down. And it seems to be that there is some more interest in understanding the way that this impacts our country and putting bipartisan policy forward. Like I said, the Mental Health Parity Compliance Act is bipartisan. We introduced the Stopping the Mental Health Pandemic Act, which is also bipartisan and would funnel millions of dollars to our states to help cover and increase access to mental health care during this crisis. And we really haven't seen a lot of opposition to some of the things that Deborah mentioned that have increased access to care during the crisis. Rules that prevented telemental health from being accessible that were immediately lifted as soon as this crisis happened. And I'm hopeful that we can make sure that some of those stay waived after this crisis is over. I also think that there is a lot of funding for states to support healthcare during this that's already been passed, and I think we'll have a lot more that's coming. And I think states are not going to want to lose that. And I think that that will encourage future policy that invests in healthcare at the state level from the federal government. So.
Great, great. I mean, that sounds really optimistic. But no, I think you made a lot of really great points. I mean, I think you at the beginning, as you said, Oklahoma is one of the most conservative states in the country, and it was a narrow margin, but they did it. They voted for expansion. Missouri is voting on, I think it's August 4th, on Medicaid expansion on the ballot. And I think with Oklahoma now moving towards expansion, that makes the majority of Republican members of Congress representing expanded states. So it definitely seems like there should be an opportunity for some bipartisan support of Medicaid. So definitely looking forward to that. Okay, so I'm going to go to some audience questions now. I know we've got several that have come through. And here are our final poll results as well, thinking about long-term solutions. Lots of votes for instituting a public option in the individual market to compete with private coverage. And then in second place, stronger regulations, such as banning the short-term plans we've talked about and addressing network adequacy, which we also talked about quite a bit as well. This question I think maybe is best for you, Deborah. Somebody has asked about medical debt or medical bills lead to medical debt and can bankrupt people, especially young people who lack a lot of net savings. Can you speak to somebody's ability, I think, to claim bankruptcy due to medical debt? Maybe explain what people's options are there.
I'm actually not probably the best person to answer that. I did not work with that directly, but at least what I can talk about comfortably is that when folks do experience these medical bills and that turns into medical debt, they have some additional options that are available to them. Bankruptcy is one of them. But on top of that, there are ways to fight against the debt collectors that are not available to folks when you're just fighting against a medical provider. And those are in the Consumer Protection Acts. So there are a bunch of options out there, and those are, again, sadly, times where getting an attorney to help is really the best way to do it. But there are in every state legal services organizations that do these kinds of work. And so when that issue does come up, I highly, highly encourage folks to reach out to their legal services organization and ask for assistance, because there are remedies out there, and those folks will be able to speak to which ones are best suitable to meet you and your needs, as well as what protections are afforded to you in your own state.
Great, thank you. Any other thoughts on that question? I can keep looking. I think we've got a few more in here. Okay. Well, actually, I think we've addressed most of these. I know we are running up on our time. We were planning to try to wrap up by 4:15. So maybe I'll end it on this last question and open it up to the whole panel for your thoughts and kind of closing comments. But where do you see momentum for progress in addressing medical debt, either in 2020, and Jessica already spoke to that quite a bit, or in 2021, thinking about what the government might look like next year to kind of address affordability, further expand protections from medical debt?
I think in some states we're seeing a lot of positive movement. For example, in California, we've expanded our coverage to cover all adults up to 26 despite immigration status. And more recently, California has extended our special enrollment period, which goes until July 31st. And you can enroll in Medi-Cal year round, which is big and a step in the right direction. And helps to work towards ensuring all young people and all people have access to care when we need it. And so California actually has a lot of options, but like I said previously, if people don't understand what's available to them, if they don't know, then it's almost as if we don't have it and it's not accessible. So I want to be clear that COVID-19 is exposing the many negative realities of our healthcare system, especially for those who are most vulnerable. and there's still more work that that really needs to be done to address this. There is no healthcare system if all of us are not covered, and I mean covered for real, quality healthcare. The disparities between healthcare are real, and the access. So we have to be able to actually afford and access care regardless of our citizenship status or employment status. And if not, we're just creating other broken systems. So we can't have a structure that allows us to see a doctor, but then be inundated with bills and debt that we can't pay. So I know I and every young person I know supports universal healthcare, universal care, and we're ready to move into 2021 and hopefully move past COVID-19 crisis into reimagining our healthcare system.
Building off of what you just said, I think moving into 2021, if we possibly have a Democratic Senate, which is still a question, I think that it's very real possibility that we could have a public option moving forward. And I think that it will be a really, really important first step in reimagining what our healthcare system looks like. The Affordable Care Act is a landmark piece of legislation, and it's really expanded care for so many people, but that affordability promise is something that a lot of people still haven't actually gotten to realize. And expanding Medicaid, creating a public option, moving towards some sort of other system. Like Tanisha was saying, I think there are a lot of young people who are at this point kind of struggling to understand why we haven't moved forward, and why a universal healthcare system seems so out of the question. And I think that we are moving in that direction, and depending on what happens in November, we could be moving there a lot more quickly. But I think one of the big things that we need to do is make sure that whatever reforms we're making make the system less complex, because the reality is that most people still open an EOB when they get one and don't know what it means. It is one of the most confusing documents that you can receive. I'm sure it's something that Deborah and Diana are helping people understand all the time. My boss did a video with Wendell Potter earlier this week, where we broke down what a copay is, what a deductible is, what coinsurance is, what you actually owe, how to deal with it if you cannot pay, or if you don't think that you should have to pay. And this is something that, you know, there are people who can provide these services, but the system should be less complex to begin with.
Absolutely.
And on a similar note, I think that a lot of the things we talk about that are, very important to helping people avoid medical debt, things like surprise billing regulations or, mental health parity, obviously they're extremely important, but at the same time, those changes don't extend to people who don't have coverage for whatever reason, whether it's because of their immigration status, or, if they might live in a non-expansion state, they fall within the coverage gap. So I think that, similar to what Jessica and Tanisha said, it's very important to move forward to a system where that's, if we're not able to provide healthcare for everyone, then at least have some of these consumer protections in place for people regardless of their coverage status.
Yep, and I want to build on all of that and say that, yes, a public option would be incredible. In the meantime, I really hope we can get more states to expand their Medicaid. If nothing else, the economic fallout from COVID is highlighting a need to protect Medicaid and make sure that folks have access to it, and that we shouldn't be relying so heavily on insurance-based coverage, and that this is really a need. There shouldn't be anyone in 2020 in the United States that doesn't have access to affordable coverage. And I'm also hoping that, as Jessica mentioned earlier, more states are passing legislation to codify the protections of mental health parity. But that still isn't every state, and it's still not sufficient because it doesn't apply to all plans. ERISA plans are one, but like another huge gap Medicare doesn't have to comply with parity. So there are so many more areas where we need to ensure that health plans are offering equitable and affordable coverage of mental health and substance use disorder services. And there's a lot of work to be done, but I strongly feel that there is the momentum to do that as states have started passing these laws. And again, to call out Oklahoma, they were one that passed one of these state parity laws. Like, who knew, right? So there's a lot of options and a lot of momentum, and I'm excited to keep working on all these issues and hopefully, create a world in which we can prevent folks from incurring unnecessary medical debt when they're seeking mental health care.
Great. I mean, thank you all so much. I don't know about you, but I feel pretty inspired by this conversation. I mean, there's obviously a lot of issues that we need to address, but there's so much good work that is happening. I think, as you've all stated, the COVID pandemic has really just shined a spotlight on the inequities in our healthcare system and just the absurdity that not everyone has access to coverage, and that you are being charged thousands of dollars for something that you cannot control, and that there's a lot of work that needs to be done to fix that. But there's a lot of momentum to fix that. I think, as we've talked about across the aisle, I think across public opinion, people really do value universal coverage. Medicaid expansion would get us almost to near universal coverage for young people if all 50 states expanded. And Oklahoma is maybe setting us on that track. So I feel very excited to continue this work. Thank you all again so much for taking the time to share your time with us, share your expertise with us. On behalf of all of Young Invincibles, I want to thank our speakers. Thanks to everyone who has attended this session. This concludes our Advancing Young Adult Health series as a whole. But don't worry, we are starting a workforce series next month. Our first series on workforce issues impacting young people kicks off on July 16th. So until then, please check us out at younginvincibles.org and follow us on Twitter, Instagram, Facebook. Thanks again to everyone. I hope you all have a wonderful long weekend, and wishing you all the best. Thank you.